Mitochondria are fascinating organelles because they are these little tiny batteries present in every cell in the human body. And the reason why we need mitochondria is very simple. It's there to produce energy because we need energy for everything that we do on a day-to-day basis, and your cells need energy to function properly. And in terms of human disease, starting in 1988 with the identification of the first Leber's mutation by Dr. Doug Wallace, we now know that there's a whole range of these pathogenic mutations, these spelling mistakes within the mitochondrial genome which can cause human disease. And there are more than 200 of these pathogenic point mutations that have been reported. And at the same time, you can also have a situation where parts of the mitochondrial genome is deleted. And these mitochondrial DNA deletions are also an important cause of human disease. And the reason why I'm mentioning this is because it is really something which is becoming increasingly relevant in terms of mitochondrial medicine. When things first started, people used to think that mitochondrial disorders were very rare, but actually we now know that it affects at least 1 in 5,000 people in the general population. And I'm sure that as people have better access to genetic testing and more genes are identified, this figure will simply go up. And what sometimes makes the diagnosis quite difficult is patients can develop a whole range of clinical features. And both within and between families, there can be a wide range of presentation with the same mitochondrial mutation. And the reason why I got involved with mitochondrial disorders, well, nearly 14 years ago now, is because I got interested in the ocular side of things, because we now know that more than half of these patients will develop significant eye problems. And as Valeria mentioned this morning, optic nerve involvement is a classical manifestation of mitochondrial disease, and the paradigm is this condition Leber's optic neuropathy that I'm going to talk about now. So LHON is a primary mitochondrial genetic disorder, as all of you in the audience will know. And if we look at the actual mutations involved, 3-point mutations within the mitochondrial genome account for the vast majority of cases. And these mutations are located by their position. So you have 3460, 11778, and 14484, with the 11778 mutation being the most common mutation worldwide, except if you're in French Canada, where 14484 is much more common because of a founding event. And retinal ganglion cells are these specialized cells at the back of your eye. And the reason why we have these retinal ganglion cells is because they convert visual information into electrical signals. And then these electrical signals are sent to the brain to be processed, and that's how you see. And the axons of these 1.2 million retinal ganglion cells converge into a bundle to form the optic nerve, which is a cable connecting the eye to the vision centers in the brain. And this is a big mystery in this condition, because in a vast majority of patients, these retinal ganglion cells are the only cells which are affected, causing visual loss. There are a lot of theories, and there's more data now about why retinal ganglion cells should be preferentially affected, which I'm not going to cover. But this is a major area of research, because if we can understand this preferential vulnerability better, then we can come up with better treatment. And in terms of how patients with Leber's optic neuropathy present, it is one of the most dramatic presentations in neuro-ophthalmology, where patients will present with painless central visual loss, normally in one eye. But sometimes in 25% of cases, both eyes are affected at the same time. And there is severe reduction in vision, down to 660. That's just the UK notation. 660 is the top letter on the standard vision chart. So we're talking about very significant severe loss of vision here. And if only one eye is affected initially, the second eye usually becomes affected 3 to 6 months later, but definitely within a year of the first eye being affected. So this is really the classical presentation of this condition, bilateral loss of vision, normally in young adult males. But what I want to focus on for the remainder of this presentation are patients that have LHON plus syndromes. It is a bit of a vague term. It encompasses quite a lot of different conditions, but I think it's quite a good term to use here, where we want to put the focus more on the extraocular features. So what most people in the audience want to know is whether or not the disease is only limited to the optic nerve when a patient has a classical mitochondrial DNA mutation that causes LHON. And in the majority of patients, the answer is yes, it's only the optic nerve which is affected. And except for visual loss, most of these patients lead normal, fit, healthy lifestyle with no impact on their life expectancy. So this is classical LHON. There's a bit of feedback here. Patients normally have one of these three classical mutations, 3460, 11778, and 14484. It normally affects young adult males, and there is a bilateral loss of vision. But as I've mentioned already, you have a huge number of these mutations, these spelling mistakes within the mitochondrial genome. And if you open any textbook or any paper or any website, you will see that there's a whole range of these mitochondrial syndromes that can be associated with these mutations. I'm not going to mention all of them, but some of them are still known by their classical names, for example, NARP, MELAS, MERF, Lee syndrome. And it really tells you that very often as doctors we struggle with coming up with a diagnosis, so we just use a term, but now we know that the same term like MELAS can be caused by different mutations. And as part of these various mitochondrial syndromes, of course the optic nerve can be affected. But normally it is part of a cluster of other neurological features, which very often are much more significant compared to the optic nerve being involved. So this is really where things can overlap. You have an overlap between classical LHON and then these mitochondrial syndromes. And I'm going to mention some of these overlap syndromes to you. So this is nothing new. Even before the gene was identified, people knew that some patients with classical labors also develop other extraocular features. But the difficulty has always been that LHON is a rare disorder, and on top of that, some people develop extraocular features, so it's an even rarer group. So how do we know whether this is actually related to the LHON mutation or whether this is just a coincidence? And this is a very difficult area. So I'm just going to mention some of the extraocular features where there's probably a bit more evidence to suggest that there is a causal link between the mutation, visual loss, and the extraocular features. I'm going to talk about brain problems that might be linked with labors. Some patients also can develop muscle weakness, peripheral nerve problems, hearing loss, and I'm going to mention cardiac problems because it's something which is relevant in terms of something that could be potentially life-threatening. So let's start with cardiac problems first. So this paper was published back in 1994 by Professor Ivani Koskilainen, where she did a study of 24 families with LHON. And what she did was basically look at ECG recordings, to look at heart tracing from these patients, to determine whether or not there was any abnormal heart rhythm. And what she found was that 5 out of 51 patients, about 10% of them, had ECG features of the Wolff-Parkinson-White syndrome. So Wolff-Parkinson-White syndrome is just a cardiac problem where patients can develop palpitations. And in her study, 2 of these patients had ventricular tachycardia, which is a cause of sudden cardiac death. So it's an abnormal heart rhythm that needs to be treated because it is definitely life-threatening. But because this is an important question to clarify, other research groups have looked into this question of whether patients with LHON have an increased risk of cardiac arrhythmias. And this is one study that was carried out in Australia by Dr. David Mackey. And in this study, he did not find any increased frequency of cardiac arrhythmias comparing affected carriers and unaffected carriers compared with controls. And certainly also, I'm going to mention the Rhodos trial that looked at treatment with idebenone in patients with labors. But in this study, as part of a trial, you have to be very rigorous. So all these patients had a baseline examination where they also had ECGs. And none of these patients had any significant ECG abnormalities like the Wolff-Parkinson-White syndrome. So overall, the message seems to be that patients with LHON do not have an increased risk of serious cardiac arrhythmias or sudden cardiac death, And it could be that a study from Finland is geographically related, that these patients might have some other predisposing factor to develop cardiac arrhythmias. It is certainly sensible to carry out a baseline ECG if there are cardiac symptoms like palpitation. And in any case, most patients will have an ECG at some point by their family doctor or by their internal family physician. But I personally don't think there is an increased evidence of cardiac problems in patients with LHON. So moving on to brain problems. If you look at LHON in PubMed or Google, there's a whole list of case reports or anecdotal stories of patients with LHON developing other disorders affecting the central nervous system. And again, the main thing that we need to do is to look at the evidence and decide whether or not there is a true causal relationship or whether it could just be coincidence. Whether it's a coincidence or not, it still has to be detected, it still has to be treated, but as scientists, we always want to establish whether there's a clear link between the mutation and between these extraocular features. And I'm going to mention 3 extraocular features where there is more evidence to suggest a causal relationship. I'm going to talk about dystonia, myoclonus, and also importantly, multiple sclerosis. So dystonia is the first thing I'm going to mention. It is a movement disorder which is caused by faulty brain signals. And what happens in dystonia, patients develop uncontrollable and sometimes rather painful muscle spasms. And because of these muscle spasms, parts of the body can get pulled into abnormal postures and abnormal positions. And I've just mentioned these 2 papers here. I don't have a laser pointer, so you can, I'm just going to point towards them. There are other case reports thanks very much, Lisa. There are other case reports in the literature, but this is a case report from Nijmegen in the Netherlands and a series here from the Newcastle Mitochondrial Group 1 base. And overall, if you look at all the data, you can make a case that there is a possible association between dystonia and Leber's optic neuropathy. So the other extraocular feature I'm going to mention is myoclonus, which again is a movement disorder caused by abnormal brain signals. And in myoclonus, you get these involuntary electric shock jerking of a muscle or group of muscle. And although it's not exactly the same, that's what we sometimes get when we're just about to fall asleep, where you get this sudden jerking of your body. And these papers have come from Valerio Carelli's group from Bologna. And again, if you put all the information together, you can make a case that there is a link between myoclonus and the LHON mutations in some families. It's still rare, but the link can be made a bit more strongly. So I'm going to talk now about the link with multiple sclerosis. And Valerio mentioned that already in his talk, but neurons are really beautiful things because here you have a neuron with a cell body, and with the axon here, which is basically a cable that's going to connect to another neuron. And the cable here is connected, is protected by this myelin sheath to help the electrical signal go down the cable much faster. And what happens in multiple sclerosis is a complex disease, but you get loss of this myelin coating. And this is the pathological hallmark of multiple sclerosis. So patients with multiple sclerosis can develop a wide range of neurological features, but visual problems are very important because more than 40% of these patients will develop visual problems at some point because of inflammation of the optic nerve, which is known as optic neuritis. And when you do an MRI scan, you can see evidence of inflammation of the optic nerve, like in this patient here, where the right optic nerve has this abnormal bright signal, which indicates that there is inflammation there. So I'm just going to mention optic neuritis because very often patients with LHON initially get diagnosed as having optic neuritis before the penny drops that actually no, it's not optic neuritis, but it is a mitochondrial optic nerve problem. So in optic neuritis, there is acute reduction in vision in one eye over a few days. The majority of patients will report pain around the eye, and very often the pain is worse when you move the eyes around. And the thing about optic neuritis is that there's very rapid visual recovery without treatment. So this is a very important paper that came out in Brain in 1992. I've provided you with a reference here, with Anita Harding being the first author. She was a very prominent neurologist based at Queen Square in London. And the last author is Alistair Compston, who is a world expert in multiple sclerosis. And this really fascinating paper, they describe 8 female LHON carriers with the 11778 mutation. And in addition to visual loss, these female carriers also developed a neurological syndrome that was indistinguishable from typical multiple sclerosis. And that's why some people refer to this LHON-MS overlap syndrome as Harding's disease. So I'm just going to illustrate that with an example of a patient that I saw recently in my clinic with my neurology colleague, Patrick Chinry. She's a 37-year-old woman with multiple episodes of sequential visual loss in both eyes. She had her first episode of optic neuritis, what was thought to be optic neuritis, back when she was 17 years old. And every time that she had an episode, she recovered vision, but never fully. So she lost a bit of vision every time she had an episode. So this is just her vision when she was last in clinic at the end of last year. And 660 is the top left on the vision chart, 636 is one line below. So over the years, she's developed significant loss of vision, and both optic discs were pale. And if you look at OCT here, which is just a way of measuring the thickness of the nerve fiber layer, you can see that there's been significant loss of these retinal ganglion cells over time. But then what became quite interesting is, as she was investigated, this is her MRI scan, and she had these classical periventricular white matter changes that you see in multiple sclerosis. She had a spinal tap, and there were unmatched oligoclonal bands in the cerebrospinal fluid. And what this means is these bands give you a clear indication that there was an immune process, that her body was mounting an immunological reaction that was causing loss of myelin around the nerve cells in the brain. So that's why a lot of patients we suspected multiple sclerosis will be having a spinal tap as part of the investigation. And to cut a long story short, she met the diagnostic criteria for relapsing remitting MS as she was being followed. But then her brother also developed visual loss later on, but that was a classical LHON presentation with bilateral loss of vision happening within 2 months of each other. And he was found to have the 11778 mitochondrial DNA mutation. And the brother, unlike the sister, only had visual problems. He did not have any LHON plus features, and he did not have any abnormal MRI changes. So all of this kind of led us very recently to have a look at this overlap syndrome of LHON-MS. And the work was done by Jerry Pfeffer, who was a research fellow that came from Canada to spend 3 years to do his research with the Newcastle Mitochondrial Group. And the 2 main questions was whether there was any difference between classical LHON and LHON-MS, and secondly, whether LHON carriers had an increased risk of multiple sclerosis. So as part of this study, we were able to review 56 patients who had LHON-MS. And the first one I want to make is that this overlap syndrome is associated with all 3 primary LHON mutations. Most of them had the 11778 mutation, 80%, but there were carriers with 3460 and the 14484 mutation, because originally Anita Harding described the link with 11778, but now we know that all 3 of them can be associated with LHON-MS. So I just want to show you this table just to make a comparison between these 3 diseases: classical LHON, optic neuritis, and LHON-MS. The first part I want to discuss is the sex ratio between male and female. So as we know already, Leber's optic neuropathy is a disease of young adult males, and the figure can vary, but males have 4 times the risk of losing vision compared to female carriers. When we look at optic neuritis, it's the reverse. It's a disease with female bias, where you have 3 times more affected female than male patients. And for LHON-MS, there is a female bias with twice as many affected women as men. In terms of age of onset, there's nothing much to say here because it's a disease that tends to affect young people in their third and fourth decades of life. Ocular pain is interesting because it's very unusual for patients with classical LHON to report pain, whereas in patients with optic neuritis linked with demyelination and multiple sclerosis, the majority of patients will report ocular pain, more than 90%. And in LHON MS, it's about 50%, so not as much as in classical demyelinative optic neuritis, but certainly very different from classical LHON. And in terms of visual recovery, unfortunately, visual recovery in classical LHON is very limited. It's very good in optic neuritis, and it's only partial in LHON MS, like the case I presented, this lady who, every time she had an episode, she lost a bit of vision, so over a period of 20 years, she ended up with significant loss of vision. So LHON MS appears to be distinct from both classical LHON and classical multiple sclerosis. And I think that's one of the things that most people in the audience will want to know. And certainly looking at the data, there was no convincing evidence to suggest that a LHON carrier has an increased risk of developing multiple sclerosis. So the obvious thing is whether LHON MS therefore represents an interaction between two distinct disorders, because this is very important in terms of understanding the mechanisms leading to retinal ganglion cell loss. And there is increasing evidence that mitochondrial dysfunction is very important in terms of leading to axonal loss in multiple sclerosis. And these are just two papers published by members of the Newcastle mitochondrial group, where they've looked at this link between mitochondrial dysfunction and loss of neurons in multiple sclerosis. And as we know, right, okay, the reason why we have these mitochondria in our cells is to produce energy. You have all these complexes here on the inner membrane of the mitochondria, complex 1, 2, 3, 4, and 5. And these are embedded within the inner membrane. And all three primary LHON mutations affect complex 1, right? So basically, if complex 1 is no longer working properly, the whole chain becomes disrupted, and you get a reduction in the amount of energy which is being produced. And because you have a lot of these electrons floating around here, you have also increased levels of these reactive oxygen species, which are pretty nasty stuff for the cell because they increase the risk of your cell dying prematurely. So really the interesting story here is that these pathogenic LHON mutations could therefore be potentiating axonal loss and leading to increased neurological disability. But this is really among individuals who already have a pre-existing predisposition to developing multiple sclerosis. And I think the last thing I want to mention here, and this is very new and this is very exciting in terms of mitochondrial research, there is increasing evidence that the release of mitochondrial DNA from damaged neurons can also trigger inflammation and precipitate cell death. So if you have a cell which is in trouble and the cell explodes because it's dying, you release all these mitochondrial DNA, which then trigger inflammation. So you have a scenario where optic nerve damage in LHON could therefore contribute to an immune process, which then leads on to an immunological cascade that eventually affects the brain, and then you get these abnormal white matter changes in the brain. So this is still an evolving story, but my personal feeling is that it's telling us a lot of fundamental facts, not just about Leber's optic neuropathy, but also about demyelination and multiple sclerosis. So just to summarize the main points, because I know I've covered quite a few things here, the majority of patients with LHON will only develop bilateral visual loss. And I think this is an important point to make. Extraocular features have been associated with all three primary LHON mutations, and there's a whole list that I could put here. But the one thing that we need to keep in mind is that it is quite difficult to establish a causal link between these extraocular features and LHON MS. And what I've done is basically focus on those where there's much more evidence in the published literature. And whether or not it's linked with a LHON mutation, as doctors, we need to be aware of it, because if your patient has any of these extraocular features, you should make sure that it gets treated and managed properly to reduce the risk of secondary complication. Thank you very much.